Jimmy, our fellow from DIP.io, will be presenting first. So let me pull up the slides, Jimmy, and then I will pass it straight to you.
Thanks, Morgan. Well, I'll start whilst you're doing that. Morning, everybody. It's really lovely to see so many people here this morning in these busy times, taking an hour out for some reflection about innovation and change. I'm going to talk about 11 million people in the UK that are at risk of chronic kidney disease, which includes people with diabetes, as I'm sure you know. The problem I'm highlighting are the 40,000 premature deaths each year amongst people with CKD, 40,000. And quite aside from anything else, that's costing the NHS 1.5 billion pounds a year in care costs like transplant and dialysis costs. So I'm Jimmy Endicott from Healthy.io. We're the first health tech company in the world to achieve CE accreditation for the smartphone camera as a medical device. And I'm going to tell you how we've been helping close this gap in care, like we were all urged to do in the long-term plan to close gaps in care pathways. But during COVID, particularly with additional limitations on care pathways, growing pressure on GP surgeries, we've been proving how innovative home testing for urinary albumin can help GPs redress the balance at scale in the NHS. So next slide, please, Morgan. So as you probably know, NICE recommends annual urinary albumin testing, or ACR testing, for people at risk of CKD, particularly the 4 million people with diabetes. Traditional care models aren't engaging these at-risk patients. Many don't complete all 9 of the essential annual care processes in the diabetes annual review. As you can see on this slide, urine ACR testing has the lowest uptake of them all, with only around half of the at-risk population sometimes completing their test. This is an issue because having undiagnosed kidney health problems puts people at diabetes at increased risk of developing complications like progression of CKD and cardiovascular disease. So increased compliance in ACR testing, which is our field of work, is a critical area for improving the quality of care for these at-risk people, as highlighted by NICE. Next slide, please. So let's try and understand why compliance is so low. Imagine you're a patient with diabetes and you're due for your annual urinary albumin test. So you've got to get a first thing in the morning GP's appointment to provide a sample, which during COVID has been easier said than done. You've got to go and collect, or you've got to go and collect a sample pot from the GP surgery in advance to provide a sample. You've got to produce a sample, take it back to the GPs in your pocket or your handbag when you go for your annual check. If you forget it, or you didn't really want to do it, you'll have to do it again in the public toilet at the GP surgery, or you'll get another sample pot to take home. You'll have to bring it back again once you've produced the sample, hand it to the receptionist over the counter in front of the whole waiting room. And when the GP finally receives the sample, then it's got to be sent to the hospital for tests to be performed. Then the results get sent back to the GP, who would then have to pass them on to you. So there's lots of toing and froing, which all consumes patients' time and obviously critical NHS resource time. So there's lots of points where the process can break down too. Next slide, please. So we were cited on this, and we were actually ready to react when COVID hit. We'd first been working with NHS teams back in 2018 to design and introduce a fully integrated digital ACR testing pathway. We took a list from the practices of all the people with diabetes who had not done an ACR test in the last 12 months, and we onboarded them over the phone remotely and with an SMS text message, which gave them use of this, our home testing app. So I can show you it now. So here's Emily. She's the resident virtual nurse in our app. She's a chatbot who talks to users through the albumin test to enable a 99.5% usability of the product amongst 18 to 80-year-olds. She does things like test the lighting conditions, ready for your scanning your dipstick, and she'll talk you through the process of the test and help make sure that you take a valid scan of the dipstick once you've dipped it in your sample. And so once we've onboarded patients and they've downloaded the app, they'll receive through the post our testing kit. The kit comes through the letterbox, and then they're talked through it by Emily the process of filling the pot, which is in the kit. So we have a little pot comes in the kit through the letterbox. And also within the kit is the dipstick here and the colour board, which will help us to read the dipstick after you've produced a sample and tasted it. So you place the dipstick on the colour board, you take a scan through the app, and you're using your own mobile phone camera. And then the result goes up to our UK-based cloud, and an algorithm translates it into a digital grade clinical result that's substantially equivalent to a point of care automated analyzer. The result is sent to the user's phone in real time, immediately, and also to the GP, so it can be acted upon. Next slide, please, Morgan. So in our very first programme with modality GPs in Hull and Airedale up north, 92% of 500 patients we tested said the test was very easy or easy to do. 96% said they preferred testing at home and would like to do that in future rather than testing in the GP surgery. And clinicians said it was quick, convenient, and it reduced patients' anxiety about providing a sample. 72% of the eligible population consented to taking the test and provided a sample. That's an excellent outcome compared to usual, typically low ACR testing rates across the country. We went from zero compliance amongst the untested population to 72%. And actually 11% of those people were found to have a raised ACR. Next slide, please. During the pilot, we also ran the Academic Health Science Network commissioned an independent evaluation, which we ran with York Health Economics Consortium to examine the impact. And this produced this model, which was published in a peer-reviewed journal. And it showed that if we could just reach 30% of the untested population of people with diabetes in England, we'd save the NHS £209 million over 5 years in costs saved against care like dialysis and transplant. If we actually extended this to include people with hypertension, another at-risk cohort, we'd save £660 million in reduced costs of care. So significant savings impact. Next slide, please, Morgan. This is the last slide. I'm just going to summarize some of the key impacts of this innovation. The first one being the substantial potential for savings if deployed at scale, which I've just talked about. Also, the impact for people at risk of chronic kidney disease. Compliance for testing is actually up now, so we've seen it increase, particularly during COVID as we've deployed more widely. So compliance is now more like 80%, and identification of people with raised proteinuria is as high as 25%, something like a quarter. And based on those findings from the York Health Economics Consortium, we can calculate the savings impact in any CCG, STP or ICS area. So we can produce you a tailored report. I'll actually post the link in the chat and I'll send it around with Morgan afterwards if you want to request a tailored report from us that would show you the health economics of the impact of an innovation like this in your area. The next impact is the potential to move to a whole at-risk population testing model, a digital first model, especially in these COVID times when the pandemic's been hitting local practices really hard. This outsourced approach is helping GPs release resources, especially now with a mass vax program coming online big time and consuming GPs bandwidth. Here's a way to outsource a whole bundle of stuff that GPs practices normally have to do, outsource it to an external supplier. And we've seen during COVID the increased appetite for digital adoption, this becoming more and more popular. We're ready to scale. We've just been commissioned by the Accelerated Access Collaborative through the AI in Health and Care Award to deploy this to 600,000 patients, and that's already underway as a program. So if you were ever unsure that the mobile phone could be used as a diagnostic device, here's proof that it can be at scale in a program that closes care gaps for people with diabetes and can release significant savings in the NHS. Thank you very much.
Thank you, Jimmy. Arjun, I think, from Low Carb Program, if you're ready to pass it over.
Sure.
Great.
Hopefully do you want me to share my screen or do you have my slides there? Perfect. Brilliant. Good morning. My name is Arjun Panesar, and I am the founding CEO and head of AI at DDM, makers of the low carb program. I started DDM after my grandfather's quadruple heart bypass over 18 years ago and diagnosis of type 2 diabetes. And today we welcome over 1.8 million members across our services. This morning, I'll share a little more about our low carb program app, how our focus was shifted during the COVID pandemic, our outcomes, and some key COVID learnings. So moving on to the next slide, please. What is the low carb program? The low carb program is an evidence-based behavior change app that tackles type 2 diabetes by addressing the aspect of health people feel most empowered to tackle first, nutrition. The app helps people reduce their carbohydrate intake to around 130 grams per day and is approved for use by people diagnosed with obesity, prediabetes, type 2 diabetes, non-alcoholic fatty liver disease, and polycystic ovarian syndrome. The app helps people reduce, I mentioned that. The app is available on the web, mobile, smartwatch, voice-activated assistance, and VR, and is used by 450,000 members. The app is also NHS Library approved and currently commissioned in a dozen CCGs. The low carb program is also the highest ORCA rated app in the category of diabetes, scoring 92% across 3 categories, and in July of this year was ranked first for type 2 diabetes prevention. Moving on to the next slide, you'll see that the low carb program starts with personalized structured education. Members participate in a core 12-week initial nutrition and wellness program that is tailored to their disease profile, ethnicity, age, gender, and location. And education continues for a year with new monthly education modules after those 12 weeks. Moving on to the next slide, you'll see that dietary approaches can be chosen by the patient or set by the healthcare professional. The platform now doesn't just support low carb, but also supports ketogenic, balanced, and Mediterranean diets. Education is also then further personalized, moving on to the next slide, please, to people of South Asian and Middle Eastern descent, with education and meal plans delivered in Hindi, Punjabi, and Arabic to maximize engagement and health outcomes. On the next slide, you'll see that patients can find support from behavior change coaches and from over 450,000 peers with similar goals. And then moving on to the next slide, you'll see that there are interactive resources to support positive health behaviors, such as tailored meal plans and AI-powered library of recipes. These recipes are tailored to users based on their allergies, favorite foods, time to cook, budget, and cultural preferences. And it's a feature I like to affectionately call recipe flicks. Meal plans support British, South Asian, Arabic, North and East African, European, and Chinese cuisines. Moving on to the next slide. Earlier this year, we saw, in March, we saw the low carb program usage or bandwidth usage surge by around about 300% week on week. And at the time, we couldn't quite understand the reason for this. We weren't receiving more referrals. This was literally participants within the app using the app more. And we could see that they were reading posts, engaging with the recipes, looking at education, or what was increasing was the usage of health coaching. We realized very quickly that this surge was completely catalyzed by COVID. As the evidence base regarding poor metabolic health and risk of COVID complications grew, so did the usage of the platform by the participants who were already within it. So we proceeded to survey just over 3,000 users and listen to what they wanted. Respondents wanted coping strategies to minimize the risk of catching and spreading COVID, dealing with lockdown, but then also they wanted help to prevent them from feeling isolated and methods to stay active at home. Our most immediate learning was that mental health and well-being support was urgently needed. We learned very quickly that people with diabetes felt lonely and were struggling. Standardized questionnaires completed by members showed 2 in 3 participants were suffering with symptoms of anxiety on registration. So COVID made it more important than ever to support effective, remote patient-centered care for those deemed at risk of COVID-19 and its complications, patients with type 2 diabetes, obesity, and hypertension. And so just before Easter, we launched a COVID education series aimed at supporting patients who were vulnerable, shielding, self-isolating, or in quarantine. As you can see here, the support series stretches 11 modules and also taught patients techniques to manage fear and anxiety. Moving on to the next slide, please. We also launched, or expedited rather, as a result of COVID, our on-demand classes library to support mental health and keeping people active at home. What we know from the low carb program is that after around about 7 weeks of usage, people move for 63 minutes more. And so our on-demand classes help to support people with their desire to stay active at home, with at-home workouts, anti-desk workouts, guided relaxations and mindfulness, which were all supported by behavior change coaches. Since launch, 150,000 people, or just over 150,000 people, have taken part in an on-demand class. We also updated our Alexa app as we saw a 300% increase in engagement from Amazon Alexa users over the last 9 months. And moving on to the next slide, please. We also started regular virtual meetups as many people expressed feeling disconnected and isolated. And this has by far been the most well-received feature in regards to our COVID shift, as it has helped to keep people connected. Now, moving on to the next slide, the entire low carb program ecosystem can be managed through a clinical dashboard, which provides health and engagement outcomes to providers or healthcare professionals. But as an innovator, it was obvious to see that COVID pushed the health service in terms of activity and understanding forward by at least a decade. Before COVID, interest in remote monitoring was minimal, and I would suggest that people weren't quite sure what remote monitoring was, whereas now it's requested and expected from digital interventions. And then moving on to the next slide, perhaps of most relevance for today's topic of conversation are the results of our NHS primary care study with Warwick Medical School, as it was ongoing during COVID and concluded only a few months ago. We engaged with 4 general practices around the West Midlands who have been recruiting since late 2018 up until around about 3 months ago, and spoke to both healthcare professionals and patients. What was interesting was, because of COVID, we even had to innovate the way we signpost users to the app, as everything had become remote. Rather than being given our traditional activation cards, patients were emailed their referral code and nudged to onboard during onboarding sessions with us. On average, participants who completed the program, including during COVID, saw significant reductions in weight and A1C of 7.2 kilograms and 9 millimoles per mole, respectively, at 6 months. However, as the study assessed qualitative and quantitative measures, we were able to listen and see how healthcare professionals and patients' perceptions of digital technology have evolved. And if you could move to the final slide, please. What we learned during COVID, if anything, was that healthcare professionals are acutely aware that patients with type 2 diabetes are a patient group that require attention due to the COVID risk and complications risk. And innovative technologies and methods are certainly required to reach these groups. And from the data, what is glaringly obvious is that coping strategies are required for this growing population of people who are highlighting anxiety as a concern. Yet, that being said, COVID, as Partha alluded to, does have a silver lining, as it has shown us that it is possible to engage and sustain behavior change and engage people with type 2 diabetes with apps during these unprecedented times, and that gives us tremendous hope as we emerge out of this pandemic. Thank you.
Thank you so much, Arjun. I really like the idea of recipe flicks. All right, I will pass it over to Dr. Debbie Wake from My Way Diabetes. Debbie, if you're ready.
Great, thanks, Morgan. Have you got slides? There we go, fantastic, thanks. So my name's Debbie Wake. I'm a diabetes consultant by background and a clinical academic with Edinburgh University, and co-founder and CEO of My Way Digital Health. Next slide, please. As you've heard, these are challenging times, particularly for people with diabetes who are undoubtedly more heavily affected in the COVID environment than the general population. And so we've also been supporting people with diabetes, but also trying to support clinicians to better manage and support the population. Next slide, Morgan. So My Way Digital Health, we have 2 main products. One is called My Diabetes My Way, which is focused on supporting patient self-management. And the other is My Diabetes Clinical, which is an electronic health record platform for clinicians that supports both individual patient management, remote monitoring, but also population analytics and audit. And I'll talk a little bit about that in a minute. Next slide, please. I think a key differentiator for us in terms of our patient engagement is how we use data. So we integrate with the electronic health record and pull data through from clinical systems to make that data available to people with diabetes. We make the data visible, readily understandable. We use RAG codings. We give patient explanations, and we use the data using rules algorithms and increasingly AI to give highly tailored automated advice back to people, dependent on things like their type of diabetes, length of diabetes, and how they're performing against key performance indicators. We link this back to educational material. So we have over 200 educational resources for all types of diabetes and structured e-learning courses. Our platform also allows people to securely communicate with their healthcare professional team, and I'll talk more about that in a minute. Next slide, Margaret. So our My Diabetes MyWay platform has been running in Scotland for over 14 years. It's the national platform there, but it's also deployed in about 20 to 25% of NHS England. So if you're in any of these areas, Cheshire and Merseyside, Lancashire, South Cumbria, Greater Manchester, North West London, North East London or Somerset, then the My Diabetes platform has already been commissioned across your area and is completely free of charge for anybody with diabetes in those regions. So I would urge you to let your patients know about this, but also encourage healthcare professionals to use the service as well. Next slide, please. So COVID for us did mean quite a big change in the way that we were delivering services. The first thing that we noticed was that our public education websites, which we spring up local websites in every region that we have that contains local information, but also publicly accessible resources, suddenly we saw a massive increase in traffic to these websites. We had to spring up some advice quite quickly around COVID and how to cope with COVID. And just to give an example, in Scotland, within 2 weeks of lockdown, we had about 14,000 hits to our COVID pages, with patient feedback being just being so grateful really for clear advice as to what to do in these difficult times. So we've continued to update this and link through to things like Diabetes UK and other sort of national guidelines around COVID, and that's been really a bit of a public service offering. And next slide, please. The other thing that happened during the pandemic is that we were commissioned, as Partha mentioned earlier, by NHS England to deliver a platform for type 1 diabetes for the whole country. And as you've heard, structured education for type 1 diabetes is very poorly attended. About 7% of people with type 1 attend structured education pre-lockdown, which is mainly delivered face-to-face in an environment that isn't always accessible to everybody. So we sprung up a platform that offered over 200 interactive educational resources for type 1 diabetes. It now has 5 e-learning courses. It's available, as I say, free of charge for anyone in the country with type 1 diabetes, and we will report the results back to the general practice. Next slide, please. So just to show you a little bit more about this platform, these are the 5 e-learning courses that are part of it that people can work through in a structured way. They've been Kismet accredited, which means they qualify for National Diabetes Audit and QOF reporting. And we've courses that are complete comprehensive courses for newly diagnosed people with type 1 diabetes, in-depth courses on carb counting, courses specific for people living with or young people who have type 1 diabetes, and we have 2 courses that relate to insulin pump therapy. And people can self-refer onto these courses. It doesn't require a healthcare professional referral, and we will report back. Next slide, please. And the result of this work has been great. The courses themselves are very interactive. We use a lot of video, engaging content with healthcare professionals, patients telling stories, interactive examples. There's discussion boards and social learning so they can meet other people online. We also pair up with Carbs and Cals to supply some really good infographics around particularly the carb counting. Next slide, please. And the feedback from this national platform has been great. I won't go through this in detail, but a lot of people saying they just wish they'd known this information when they were newly diagnosed, and people who are using it to support as carers, supporting people in their family with type 1 diabetes. And as I say, it's a very flexible and interactive way of accessing education that wasn't previously available, as a lot of type 1 education was only delivered in a face-to-face contact up till recently. Next slide, please. So since June, which is when we started, so this has only been up and running 5 months, we've already had about 20,000 new users to the public education website. In terms of the structured education courses, I think by the turn of the year, we'll probably have over 1,000 registrants for these fully structured courses. And we're seeing about average course progression of about 75%. So we're really pleased with these early results, and these numbers are continuing to grow. Next slide, please. The other thing that we've done is run a number of completely free open courses for anyone around the world with diabetes. So when lockdown hit, we quickly launched a type 2 diabetes program that ran in April for just 2 days. Anyone around the world could join and take part in this. And we had about 2,000 people who took part in a 2-day online course. And at the moment, today and tomorrow, we've got a similar course running for people with type 1 diabetes, again, free to anyone around the globe who wishes to take part in this. And as well as working through online content, we're doing live streaming on Facebook and Twitter to get a really sort of engaged, interactive experience. And that's the link at the bottom there, understandingtype1.mydiabetes.com. It's not too late for anyone to sign up for today and tomorrow's course, so please encourage them to do so. Morgan, next slide, please. And what we've seen from these massive free online courses has been an amazing response. And again, it hit at just the right time, I think, during lockdown when people were struggling. The feedback from participants has been amazing, both in terms of the courses being easy to use, but also improvements in diabetes knowledge and motivation to manage their diabetes, and improvements in health and well-being. And we've published this work in BMJ Innovations. We've just gone back and done a follow-up of patients about 3 months later, and the stories that are coming back of people who've managed to continue sustained behaviour change has been incredible. This is just a quote from one patient who's lost 1 stone and 9 pounds already and is fully on track for full diabetes remission as a result of taking part in one of our free online open courses, which has been fantastic. Next slide, please. And the final area that we really support is around the data. So Partha mentioned about remote monitoring. Our platforms allow people not only to see the data from the electronic health record, but to upload their own data from things like glucose meters, activity meters. And that data can then be shared with healthcare professionals. And through our secure messaging platform, they can basically take part in a remote conversation, which reduces the need for face-to-face contact. On our clinician-facing system, as well as supplying an electronic health record, our population management system allows clinicians to triage and identify those patients who are at highest risk of complications, so that again, they can reduce the face-to-face contact for those who really need it and remotely support those who perhaps are a lower risk group who don't need that sort of intense face-to-face contact. And I think this is going to be the way of movement going forward. We're moving towards an era of much more personalised medicine, tailored medicine, not just seeing people at fixed intervals, but actually tailoring the treatment to the person and doing a lot of that more through remote mechanisms. Next slide, please. And really that was all I was going to say to finish. And just to say that I think an important part of innovation during this period has been the ability to respond to users' needs, to be flexible and to change what you're doing according to new market conditions. And I think that's what I think a lot of us have done. And we're learning a lot, I think, from having done that from the feedback from users. So continue to evolve and improve going forward. Thanks.
Thanks so much, Debbie. And I think there's a question for you in the chat, which I'll ask if you can take a look at that and respond. And last, certainly not least, to Lucy Diamond, who's the UK Head of Clinical for Oviva Diabetes Support.
Hiya, good morning, everyone. I know we've only got 5 minutes, so I will promise to power through quickly to allow for at least 1 or 2 questions for the group. So I'm Lucy, I'm the UK Head of Clinical for Oviva and a diabetes specialist dietitian by trade. So I just want to begin by giving a brief overview of who we are, what we do, and then delve into examples of how our care may have changed due to the impact of COVID. So as it says there, we are a clinically led provider of remote NHS services, and currently we provide those services to 23 STPs and 4 Scottish Health Boards. How we work is we combine one-to-one support from dietitians and coaches, supported by an MDT behind the scenes, with our NHS digital approved smartphone app and an online learn platform too. So we have an evidence-based and NICE aligned programme to support people living with type 2 diabetes, pre-diabetes and complex obesity. And luckily, as you can see there, majority of our patients would recommend our services. Next slide, please, Debbie. Morgan. Lovely, thank you. So what we do specifically within Oviva Diabetes Support is a 3-month programme. And that provides one-to-one care from either a diabetes specialist dietitian or a health coach. We aim to widen access to structured education by providing this support, but also support behaviour change throughout our programme. It is selected for the NHS Innovation Accelerator. We are on NHS England's list of approved providers. We are NICE aligned and Kismet certified, GDPR compliant, and NHS Digital DAQ certified, and also in the NHS Apps Library. Next slide, please, Morgan. So a whistle-stop tour of our patient experience whilst on a diabetes support programme. They have an initial assessment with one of our patient pathway coordinators. They are then booked in for an initial consultation with either a dietitian or health coach, which is triaged based on medical complexity, and that kicks off with a telephone call, so a 30-minute call to get to know that individual. They then can choose which arm of style of coaching they would like. So we have our Aviva app platform where you're able to communicate with your dietitian or coach on a weekly basis. If someone is not too confident in using their smartphone for communication, then we do provide remote telephone calls on a fortnightly basis during those 12 weeks as an alternative. As I said, we have the app there for the communication with your dietitian or your coach back and forward throughout those 12 weeks, but is also there as a self-monitoring tool to really cover some of the behaviour change techniques of self-monitoring and driving behaviour change and sustaining changes to diet and lifestyle. To support your interaction with your dietitian or health coach, there is an online platform which talks you through everything there is to learn about type 2 diabetes, and then also hones in on specific diet approaches to take as well as lifestyle changes to make. Perfect. Next slide, please, Morgan. So whilst our programme hasn't changed through COVID, although some of our content has really to align with the life we're all leading at the moment, really what has changed is our approach and our ability to and have to scale quickly. And one example I'd like to talk you through very briefly in these final 2 minutes is looking at our collaboration with NHS Tayside. So this is up in Scotland. There are approximately 17,000 new diagnoses of type 2 diabetes in Scotland per year, with a further 10% of type 2 remaining undiagnosed. And specifically in our Tayside population, there are approximately 1,300 new diagnoses of type 2 per year. So whilst remote and digital have been on the agenda for NHS Tayside for a while, exploring different options, actually COVID pushed that to the top of the agenda, realising that they did need to implement not only a remote digital offering, but that one-to-one support to drive behaviour change. So we worked with them, and as many of you will know, looking at mobilisation times, normally taking 6 months, we were able to collaboratively work together to build the programme and to have that turnaround in 6 weeks to be up and running. So looking at our solution there, we partnered together, we worked on the programme, and we're really trying to reach those that previously may have engaged in face-to-face care or previously not wanted to engage in face-to-face care, and tailored that programme throughout. So really just in the final minute, looking at the outcomes, so driving cost savings of 105k based on 300 patient referrals per year, working together on that redesign to release care from primary care and some of the pressures they were experiencing in primary care and dietetic services, and enabling that continuity of care for patients during COVID, particularly those at that high risk within diabetes. And within the first 8 weeks, we set up a self-referral platform. In the first 8 weeks, we had 126 referrals with a 25% conversion rate from invitation, which is double where it normally is. Participants are taking responsibility for their health and are motivated and engaged so far. We've had some phenomenal patient stories to share. Lovely. Next slide, please, Morgan. In the final 5 minutes, so what other impacts have we seen? We've actually seen a great increase in referrals across our diabetes and obesity programs across the board. We've seen thousands of patients that have otherwise been sat on waiting lists where we've been able to support people and face-to-face providers. On the downside, we've seen an increase in mental health, almost a third increase. So we've had lots of additional support from our clinical lead psychologist, really supporting the staff and training individuals to support our population that are under increased stress and anxiety during this time. And finally, we launched the NHS LCD programme that we're proud to be part of for NHS England. Final slide. It's just to really share some words of those that have encountered our services from both commissioner and patient side. So our Tayside colleague, Jacqueline, believing our approach is the future with or without COVID. as also our patient, Mr. D, found the combination of digital and one-to-one support a key factor in his success on the programme. And he went on to lose over 10 kilograms during COVID and lockdown. So we think COVID has expedited the need for remote solutions. We are digitally enabled, but also critically have that one-to-one support for participants to see good clinical outcomes in a time of need. 1 minute over, apologies. Thank you, everyone.
Wow, that was a lot to pack in. Thank you so much, Lucy. I really appreciate it.
Sorry for the speed.
It's fine. So just to flag, we will be sharing a link to a recording of this session as well as slides as a follow-up. So don't worry if you missed anything or anyone spoke too fast and you need to slow things down on your end. I know that we are 1 minute over time, but I didn't know if any of our speakers might have an extra second just to be able to address one of the questions that was popped into the chat. Professor Carr, I didn't know if this might be one you could address, but someone has asked where about the size of the gap which risks leaving people without tech or the right tech behind as we look at these types of innovations.
Yeah, so one of the things that we are doing, for example, we've done with Libra, is tracking the deprivation index about the access. So there was a big gap to begin with, but lots of the local teams have been specifically asked to make sure that that gap has been closed. So as of the latest data, that gap is very, very minimal. But I think that happens. One of the key factors is that if you develop a system whereby you have to go to see a specialist to get everything, then that gap will open up. Because, well, you know, those who are more informed, those who got more time on their hands, those who can go and park their cars will go to the hospital. So you automatically create a gap. So I think opening that up, moving that more into primary care has definitely changed that. So yes, understandable point. I think the gap is more on deprivation side of things, to be honest, rather than age, because I think that's more of a myth. As far as it's age thing that, you know, elderly people don't do this and don't do that, I don't think that's accurate. As far as we see in diabetes care, at least, you know, people use all sorts of technology. So, but deprivation is a big issue. And I personally believe that it's not just the job of policymakers, it's also the job of the providers to ensure they do what's needed to reach out to the deprived population. That's the way I think it can be closed.
Thank you so much. And we'll do one more question and then draw it to a close. But there was a question for, I think, Lucy, Debbie, and Arjun really around how, whether or not physical activity is supported through your program. So I don't know if you guys want to chime in, and then we'll draw it to a close here in the next minute.
Yeah, I can jump in very quickly. Yeah, it's a key component of our program. So we cover diet, lifestyle, as well as addressing motivational interviewing and behavior change techniques. So we try to encompass kind of body, mind, and soul within the whole program, but it is a key component of driving lifestyle changes and covered within our Learn content, but also set as goals and to-dos on a one-to-one basis with your coach.
Yeah, similarly, we have on-demand classes. So we have around about 400 on-demand classes that are tailored to the user's fitness level, and they can engage with that with support from behavior change coaches.
Yeah, and from our point of view, yeah, we've got a lot of information about physical activity, and we also integrate things like Fitbit data, so people can start to set goals around things like their step counts and so on. We don't have one-to-one coaching on our system. It's a much more sort of low-cost population delivered system, but we basically do it through automated kind of goal setting and tailored advice, which is done more through the data and the AI than the sort of supported coaching, which is when we would often sort of refer people through to services like Aviva and the Low Carb program and things for more tailored coaching.
Great, thank you. And I know I said one last question, but there is actually one that's been popped in that seems quite relevant of, we know that there's obviously so many different lovely apps, but how do we look at, or do we look at there being a point where there's one platform for everything?
Yeah, certainly for diabetes, I think that's the aim. Definitely one platform. I mean, we already have not very far off from that. I mean, Debbie knows about, we use a platform called Diasen, which comes from the Scandinavian country, which we use as a data integrator for all technology, but some companies refuse to share their data. So what stops us from saying that if you don't share your data, we don't procure your device? Not a huge amount. Could we do that? Maybe. So let's see.
I think a single platform for the data is a great aspiration. I think when it comes to the kind of behaviour change programmes and things, I think having these different options for different people is also very helpful. In Manchester, we're at the moment working with a number of different companies where we'll have a baseline platform and then people can actually pick and choose Aviva or low carb or Changing Health or different things as their kind of more one-to-one coaching programmes. So I think yeah, a base around the data, but with options for patients to choose, I think would be a good way forward.
Great. Right. Really will call it now. Thank you so much to all of our speakers. Thank you so much, Professor Carr, for joining us and for your insights. Thank you to our 4 innovators for speaking about your innovations. I know from a personal perspective, as a person with type 1 diabetes, this has actually been quite an inspiring hour for me as well, and it wasn't even meant to be. But yes, finding those silver linings in rough times, which we've had over the last year, and seeing all of these really incredible opportunities that are coming up that have, of course, existed, but that we might be able to actually see coming closer to home more quickly, is something I personally get to look forward to. So thank you so much to everyone for joining us. Very much appreciated.